morning, future PTAs. I hope you guys are doing well. We are going to talk about the knee and the ankle and foot today. So, got a lot of material to cover. We'll try and cover as quickly as we can. So, with the knee anatomy, of course, you know that the quads and hamstrings kind of surround and support the upper part of the knee. The bottom part, as far as muscles go, the bottom part is the gastrocnemius, but the main thing I want you to remember is all of the ligaments surrounding the knee. So we have the ACL, anterior cruciate ligament, and that primarily prevents anterior translation of the tibia, so the tibia from moving too far forward, and also rotational forces. With the PCL, the posterior cruciate ligament, it primarily limits the tibia from going too far backwards, posterior translation. We also have medial and lateral meniscus, medial and lateral collateral joints, so MCL and LCL, your patellar tendon, and those are really the most common tendon and ligaments that support and stabilize the knee and that might get hurt in case of an injury. Okay, as far as observation, we certainly want to look at the alignment. Remember, we've talked about genu valgus, and in this case, varus, as the knees bow out. This is before and after a surgery, so they did an excellent job correcting that. The hip alignment, you want to look at the hip and ankle anytime you're working with the knee, because it's hard to determine what came from where, whether the issue is from the knee joint, the hip joint, and which came first, the chicken or the egg, if the knee is hurting because of the hip or if the knee is also leading to hip issues. Sorry, I was trying to zoom in a little bit without losing the very bottom. Okay. Q angle, we'll go over Q angle in just a second and what to look at there. Here they're looking at the alignment, the kind of crevices or creases in the back of your knee can help tell you alignment. You can also look at the ankle. Some of this may be coming from the ankle or causing the ankle to change. So just getting a good idea, comparing one side to the other. The indentation for the IT band tells you that you have some tightness there. So look for that. Any swelling, redness throughout the knee or surrounding the joint is key. And then the patellar alignment and how it moves as the patient moves their knee from flexion to extension and as they contract their quads. So the J sign is what's being showed here, where the patella, instead of just going up and down at kind of the top of the movement while you're contracting your quad, it is pulled laterally. So that's the J sign. It starts to move up and then it tracks laterally. And typically that's with tightness in the IT band and the lateral muscles, and then weakness in the VMO. So patellar tracking is what that is. All right, with the Q angle, we've talked about that being the angle that the femur meets the tibia. And so with a normal Q angle around 15 degrees, an increase being more than 20, which causes genu valgus, or a decreased Q angle less than 10 could cause the genu varus, bow leg. So with the Q angle, first you can draw a line from the ASIS down to the middle of the patella, and then the second line goes straight up from the middle of the patella up to the tibial tubercle, and that is where you get the exact angle if you're measuring somebody's Q angle. So from the ASIS to the middle of the patella and then straight up to the tibial tubercle. And that would give you the exact measurement so that you could determine, if they have increased or decreased. Oftentimes you can just look at their legs and make a determination, but to get an actual value. If the angle is significantly more than 20 degrees, then it may actually indicate a displaced patella, that it's actually out of alignment and you're getting a false Q angle there. So an increased Q angle whenever you're already built in a way that the alignment wider hips, more narrow at the knees, then it can cause more pressure on the medial knee, as we've talked about. It can be related to IT band tightness, weakness of the gluteus medius, genu valgus force at the knee, and then can cause a lateral glide of the patella, that J sign. And all of that, as it comes down the line, would cause an increased pronation of the foot and ankle. So again, with somebody who has a increased Q angle, we probably won't change the Q angle itself, but if you stretch and kind of release some of the tension in the IT band and then strengthen the VMO and the gluteus medius, you can help relieve some of that knee pain and pressure on the knee. All right, palpation. So we will palpate all these areas in class. I did want to point out Gertie's tubercle. That's a point that they use to help find the pivot point of the knee. So Gertie's tubercle, draw a line from there to the fibular head and one line straight down from the lateral epicondyle to meet that center point, and that would be your pivot point of the knee. But we will palpate in class and find all these other areas. So we talked in class the other day about medial and lateral femoral condyles. I was searching everywhere because on the internet there are some that could then call this very lateral portion the epicondyle and the very medial portion the epicondyle. But I didn't find it in any textbooks or anatomy books. So certainly the bottom portion is the condyle. The internet may tell you that the very lateral portion of the knee is still considered the epicondyle. But again, I didn't find it in the textbook, so we'll just refer to it as the lateral and medial femoral condyles. And then we'll look through when those are painful. And then the joint line, when someone has tenderness over the joint line, it can tell you that there's a tear in the meniscus. So if it's the lateral joint line, and it's always in the front where we're kind of pushing on the joint line, then it could be the lateral meniscus that's torn. And if they have anteromedial joint line tenderness, it might be torn medial meniscus. So let's look at the pain patterns. Okay, so typically pain above the knee is from either swelling or the quadriceps tendon, tendinitis or inflammation there. Pain at the knee or at the kneecap itself, chondromalacia we'll go over in a few minutes. Patellar tracking issues, bursitis, arthritis, all would refer pain to the knee itself, especially around the kneecap. Pain below the knee, maybe Osgood-Schlatter, we'll go over that. That's typically in adolescence. Could also be some patellar tendinitis, maybe in an adult that wouldn't have Osgood-Schlatter at that point. And then pain on the outside of the knee could be the meniscus or one of the collateral ligaments that has torn or gotten weakened. Okay. So we always want to look at surrounding joints, the hip and the ankle with somebody with knee pain, just to see what all is causing the issues. Typically with the quadriceps, our focus in strengthening is VMO strengthening, and then more of the lateral quadriceps and the IT band, we typically focus on releasing or stretching. Hamstrings are typically tight, so stretching of those, and adductors are typically tight as well. So same areas we've talked about before that are typically tight. All right, with the knee mechanics. So lateral leg leads to locking. Whenever you're standing and you fully extend the leg, the tibia itself rotates exteriorly just slightly. So just a slight external rotation of the tibia itself, and that locks the knee. In order, it's during just the last few degrees of extension. In order to unlock the knee, you actually must first internally rotate the tibia just slightly to unlock it before you're able to fully bend it. I don't know if you've ever experienced that feeling that your knee's kind of stuck in an extended position, it's kind of stuck, locked. But in order to unlock the knee, you have to internally rotate it slightly. So that's lateral leg leads to locking. But the popliteus is the muscle that's responsible primarily for unlocking the knee. So as you see, the way it's attached right here, whenever the fibers shorten and come together, the primary job is to internally rotate the tibia slightly. So when you're standing and your legs fully extended, the popliteus then activates to slightly internally rotate the leg so that you can unlock it and move it towards flexion. All right, general treatment tips. So initially with the knee, we're doing kind of the opposite of what we've learned. So remember, we talk about proximal stability before distal mobility. Well, this is more of a distal joint than the hip or the shoulder like we've talked about before. So with knee, the focus initially is mobility, and then we go for stability. With the knee, if it gets to a place where it is, you have scar tissue and it's getting stuck, or there's a buildup of scar tissue that keeps you from the last few degrees of extension or flexion. If you're strengthening and that's your focus, stabilizing and not mobilizing that area, it will get stuck without the possibility of getting those last few degrees. So our focus initially is pushing extension specifically. When you're walking, you need to be able to get to a neutral position with extension, so 0 degrees of knee extension during terminal stance. And so if you're missing just a few degrees of extension, then it will become obvious in your gait. So that's key. That's the primary thing we focus on initially. Now with flexion, of course, we want all of our flexion movement, but all we really need to be able to walk with a normalized gait pattern is about 15 degrees of flexion. Our knee typically flexes passively as we're progressing our leg forward, so it's really not, it doesn't interfere with our gait as much if we're limited on flexion. Typically people have a good 15 degrees of flexion. They typically don't get stuck in a fully extended position unless, of course, maybe they've been in an extension brace and locked into that position for a long time. But so initially our focus is range of motion, with extension being the primary motion that we're pushing with knee patients. And you're also taking them through flexion as well. But a lot of your joint mobilization and your passive range of motion stuff is focusing. There's more time spent on the extension portion. All right, so some more general tips for non-operative patients. So maybe it's someone who has a torn ACL, but it's a slight tear, and they've decided to forego the surgery and just do strengthening and things to support the area. So you can check the ligaments to see if they're lax. We'll go through those different types of assessments and special tests later as far as how to check ligament stability, anterior and posterior translation of the tibia check, the ACL and PCL, and then lateral translation. So a valgus force. Valgus would be more towards the middle. Sorry. Valgus forces would be medial pressure checking the MCL, and then the varus force is the lateral pressure checking the LCL, just to make sure that the stability is there. If there's not enough stability at the knee, then a knee brace may be needed initially. Of course, the longer you wear a brace, the more you depend upon it. So you do want to limit brace wear as you're going through and doing more strengthening, especially as you're doing return to function. You eventually want to get to a place where they're relying less and less on the brace. But initially, if there's a stability issue, and really if they're playing a sport, you may long-term keep a brace during that sport just to help with stability, just depending on their needs. Quick lateral shifts and cutting movements are the most stressful on the ligament, so those are going to be kind of the last ones to practice during that return to function stage, and I wouldn't over push these if they do have a tear and are avoiding surgery. So just be careful. You want to practice enough that the only time they do them is not in the game, that they don't just wait until the game to practice those movements, but you don't want to overstress the ligaments either. Typically, anterior knee pain does not refer. It's just where it hurts is where you feel it, versus posterior knee pain often will refer down the calf. All right, beginning stages of treatment. So this is just in general for a knee patient, especially a surgical patient. What you would do kind of initially after a surgery or after an injury to the knee. And then we'll go through the specific knee problems and kind of how that affects treatment. So we would do passive, active assistive, and active range of motion depending on what's allowed. A lot of times after surgeries there are can't think of the word. There are numbers as far as how far they will allow you to flex or extend the knee. They don't want you to push it past a certain part, especially the patient themselves. Like they may have a knee brace that's locked to a certain degree that they can't, bend past or flex past a certain um, degree that the surgeon has established based on the surgery they performed. So always, of course, go by those standards. But heel slides and heel prop are often good. So typically heel slides, you kind of have a towel under your heel and you're sliding it back and forth to begin some flexion and extension, active assistive range of motion. Heel prop is just what's seen in the picture, that there is a towel roll or bolster or something under the heel, and the gravity is just pushing the knee into extension. Over time, as they need overpressure, you can put a weight, on top of the leg to help push into extension. But remember, with our joint mobilizations, that when we are going towards extension, we want a posterior pressure on the distal femur, and then you can do an anterior glide on the proximal tibia if both of those go towards extension. So typically, if we're in this position where we're going to work on the front of the patient's leg, then we'll do a posterior glide on the distal femur. So that's where I would put the weight. If I was using a weight, I wouldn't have one below. Typically, I would have it just above the knee, so it's kind of adding pressure to the distal femur as I would with a joint mobilization. That will help the most in increasing extension. We, of course, will teach patients how to properly use their assistive device, and we can start glute medius strengthening, of course, VMO strengthening as well. It's really hard for the VMO to wake up and start activating, so most of the time we will use Russian stem initially. And remember, with external input to a muscle, it first causes the larger motor units to fire and then kind of trickles down to the smaller. And whenever we activate a muscle internally, we activate the smaller motor units first, and then it kind of goes up to the larger. And so when we're doing Russian stem, we typically have the patient contract the VMO while the machine is contracting, so that the machine is kind of contracting from top down, the big to the small, and the force from inside the muscle itself is going from bottom up, so the small muscles to the big, so that it's getting fully contracted. And that would be with Russian stem is what we would call that. And there's typically the electrode placement for that. And of course, they're going to be resting from their activity. A lot of athletes, it's hard to make them do that, but if they've had any type of surgery, the surgeon has already voiced that need, but you'll have to certainly educate on that. And then ice, decreasing the inflammation. Again, swelling in the knee, just like anywhere else, can block movement, cause more pain. So icing the area, especially at the end of treatment, is key. All right, so exercise ideas for the beginning stages. CPM is your continuous passive movement or motion, continuous passive motion. So typically that's more while they're in the hospital. They'll have a machine like that just depending on the surgery and if they actually are in the hospital, because a lot of these surgeries are now done same day surgery, and they're outpatient surgical procedures, so they're released right away. So but even if they come in the clinic, if you're doing home health, that might be a possibility. Some hospitals will have a certain type of equipment like that they could check out and take home with them for the first few days, but typically that's only the first few days after surgery. Quad sets and glute sets, remember, are those isometric contractions of those muscles to start strengthening, maintaining the strength they do have while they're sedentary. Straight leg raises, so just keeping the leg locked into extension and raising up can help strengthen the quad and the hip flexor as well. We're trying to target the quad. And of course, if you kind of rotate your foot laterally just slightly, then you are increasing the focus on the VMO specifically. Here we have someone with an external fixator doing short arc quads. So that is where the knee's over the bolster and they're just doing a small movement. And then of course long arc quads, they're usually sitting at the edge of the bed and then doing kind of the full range of motion strengthening. Clamshells works on the gluteus medius, so anything to work on that you can that won't aggravate the knee. Ball squeezes, hip adduction, we'll do those some, but usually the adductors are a little bit stronger, so you don't need it as much. The bike, oftentimes we use the bike to help with some active assistive range of motion, and so they will push before they even are able to have enough motion to go all the way around on the bike. Then they'll do kind of rocking, where they rock the leg as far forward as they go and rock it as far backwards as they go, and they can kind of use the other leg to push on the pedal and push it a few more degrees each way. And that's a great warm-up at the beginning once they're cleared to be able to do something like that. If there's strict restrictions, of course you wouldn't start it, but because oftentimes they're able to relax more because they're fully in control of that motion, and they're able to really loosen the leg up before you go in and start doing your passive range of motion or any of your manual techniques. And then of course aquatic therapy, if their incision has healed and they're able to get in the pool, or if they have something to cover the incision, you don't want to get in a pool with an open wound by any means. Don't want to introduce infection, but if you're able to cover the incision, or once it's fully healed, water hydrotherapy is great because it takes the pressure off of the leg while allowing you to really do a lot of different movements with support of the leg, but also with some resistance because of the water pressure. So I highly recommend aquatic therapy, you know that. All right, treatment layout. So typically I begin with some type of range of motion like the bike or the hill slides. Typically it's more active assistive to get them kind of pushing their motion themselves while they're able to relax and push through some of the irritation or the uncomfortable portions. Then I perform my manual techniques, passive range of motion, soft tissue or deep tissue mobilization, myofascial release, that would be primarily the IT band, patellar mobs if I need to, joint mobilizations, do all of that, get as much motion as possible. Then at that point, if Russian stem is appropriate for the patient, I would do that next. Do Russian E-stem on the VMO and trying to have them do quad sets during. Now, eventually, once they progress a little bit, they could do some short arc quads during Russian stem. They could do straight leg raises just once they're starting to get a little bit stronger and able to tolerate that. Whatever other strengthening exercises that I want to do, I can do at that point. Stretching as well, stretching the IT band, the hamstrings, gastroc. And then at the end, I will typically do a heel prop, and I put before or during ice because some people like to do a heel prop with the ice and, kind of maximize that time together. But I typically do before because I usually like the heel prop for about 5 minutes and the ice for usually 10. So I will typically do them separately. But if you do, just be aware that they're going to walk out with a really stiff leg if they are in the heel prop with the ice. And so you just want to be a little bit careful. You've done all this to mobilize and now you're stiffing them back up. But you do want to use the ice for the inflammation. And oftentimes we will use E-stem. If we do, you know that you surround the knee area with the electrodes so that the current goes to the right area, and always educate them on the home exercise program, of course, throughout the session. But oftentimes at the end, I will just kind of assess and make sure they understand what they're supposed to be doing. Okay. All right, so our treatment progression. So, of course, you are going to progress your strength training as they are able and as they're cleared to do so. Eventually, from open chain, more of the short arc quad, long arc quad, straight leg raises, you're going to go to closed kinetic chain, so weight-bearing activities. Ideally, you would do that once they have good control of their glutes and able to activate those well. And then depending on pain, if they're in too much pain to weight bear, then of course you're not going to push those exercises yet. Begin strengthening throughout the full or through the increased range of motion. Sometimes with a knee patient, it takes a long time to get full range of motion, but you want to strengthen throughout the full range that they have. Of course, aquatic therapy can allow you to do a lot of different functional activities. And that's a great area to progress their movements in. And then strengthening the hip and the gluteus medius. You may start that out in supine or side lying and eventually do that in standing. Balance training, eventually progressing to single leg stance. And then, of course, progressing to active range of motion versus passive and in between the active assistive range of motion. So in general, the little asterisks at the bottom are just in general our focus of treatment. Of course, is passive range of motion, so increasing extension and flexion, but extension first is our priority, then flexion. Then strengthening the VMO and the gluteus medius, that's priority in supporting the knee. Stretching the hamstrings, piriformis, IT band, and then addressing the inflammation. Those are kind of our priority. And as we progress treatment, we go more and more towards functional training with support and with modalities and guidance so that they don't re-injure the leg. All right, advanced functional stage of treatment. Of course, you are trying to do sport-specific movements, movements if for a job that they may have, whatever they need to do for their everyday life, you need to practice those movements. So ladder drills are great. There's all kinds of lateral and forward and backwards motions that you can incorporate into the ladder drills. Retroambulation, remember, eccentrically strengthening the muscles that you need for gait. It's a great way to do that by having them walk backwards, either on a treadmill or just in general. Oftentimes we will actually, if it's a treadmill like this that has the arms, sometimes we'll tie a TheraBand to each side and they're pushing into the TheraBand as they're walking backwards, so then it's more of a resistance exercise too. But retroambulation is one of the greatest ways to strengthen those muscles. Again, single leg movements is a progression. Once they're able to maintain a good pelvis alignment and the knee not buckle and things, then progress into some of those single leg balance activities on the Bosu ball on various surfaces. You can make it more functional by adding a ball toss and catch on the rebounder or with a therapist. And then eventually increasing their endurance. We cannot bill for endurance, but of course you would never release a athlete back to their sport for full, contact or whatever they need without going through very rigorous things in the clinic. So you really may have to extend the treatment time, and the way that we write it up is increasing walking distance, increasing other things, but we don't specifically write endurance, because endurance is looked at as more of a fitness category than physical therapy. So just be aware of that. And then scar mobility. Again, make sure that you are mobilizing the scar, getting as much movement as possible as it is still immature and it's still maturing, so that as it matures, it has movement and looks more and more like the surrounding tissues, rather than getting fixed and causing range of motion limitations. And then ice is continued usually with knee patients for a while, even once they return to their sport. They'll often need ice after each practice and each game for a while. Patellar mobs, okay? So there's a video that I will put in to the play posit, but so oftentimes what will happen is the TFL is tight, and it sometimes will try and activate when the gluteus medius is weak. Again, there's that muscle imbalance there, tight hip flexors, tight IT band, weak gluteus medius and VMO. And that extra pressure and tightness from the lateral side will cause that J sign as you're activating the quad. The patella, instead of just going straight up, it goes up and laterally. So you'll put the patient in more of a slack position, so they're just kind of rested with their legs straight on the table, and move the patella back and forth to assess and determine how much movement the patella has. Typically, it should be able to translate or move about a third of its width to each side. But if it's been tracking laterally, then oftentimes as you're moving the patella itself, you'll notice that it's really tight and not able to move medially very much, but it has increased movement laterally. So then our patellar mobs would focus on pushing on the lateral side of the patella, pushing it in towards the medial border and increasing the movement there, and decreasing the tightness, and helping the patella get to a place where it tracks more in its normalized position. So whichever direction you find to be limited, it could even be inferior or superior, you can do mobilizations towards that direction, so towards the limitation. All right, so our joint mobilizations, you know that pushing on the distal posterior glide to the distal femur is what we primarily do to increase extension. You can also do an anterior glide of the proximal tibia, which increases extension as well, but they would need to be more like in prone for that. So we typically do it this way with the distal femur. And then a proximal or a posterior glide of the proximal tibia is what we use to increase flexion. You could also do an anterior glide of the distal femur, but this is what we primarily do. It's just for ease of access. So we put them in an extended position. We prop something under their calf, and then we apply posterior pressure on the distal femur to get those last few degrees of extension. When we're flexing, then we put them in more of a flex position and apply posterior pressure to the proximal tibia to help increase flexion. And then you can actually take them to a further range and do it again as a progression of that joint mobilization. All right, so the IT band loosening up, we talked about that in class last week, but you can track the borders of the IT band and do a myofascial release on the upper and the lower borders. You can also do more of that roughing like we do to the hamstrings, going on the side and just pushing pressure up along the IT band, rolling of the IT band. And then, of course, during their home exercise, if that's one of their key problems, I would include an IT band stretch so that they maintain that mobility that you're getting in the treatment. Hamstring roughing, you already know that we do that. Typically, hamstrings are tight, so we add pressure and go along the muscle fiber alignment in order to loosen those up and decrease the tone throughout the hamstrings. We can practice that again in class. VMO to Potment. So remember I talked about sometimes the VMO has trouble waking up. So as they're doing quad sets or any straight leg raises, any strengthening of the VMO, tapping over that area can help give feedback and kind of help activate that muscle. So you just, wherever, you can do it over any muscle, but specifically with the knee, we typically require some extra feedback in order to activate the VMO. So as they're doing the exercise you're leading them through, you're tapping over the VMO in order to stimulate that muscle. Typically, we'll tap while they're activating and then relax while they're in between, reps, and then tap again. And it says 5 to 10 sets. I mean, it's whatever, how many reps you're doing for that exercise. You tap over it each time. Okay, taping. Remember, we are learning kinesiotaping today, and so I won't go over a lot of that, but there's one taping that is called Mcconnell taping. So they typically lay down that white tape is more of an anchor. Mcconnell taping they often do for to correct the lateral glide of the patella, so they'll tape the patella more medially so that it maintains good alignment and is not allowed to do that lateral tracking. So you'll add a little bit of a medial pressure in order to block that lateral movement of the patella. And then you could start the tape in the middle of the patella and pull it medially to correct for a tilt. If it's tilted laterally, you can do that as well. There's all kinds of taping procedures. We'll go through kinesio taping today, but I certainly recommend taking a taping course if you're going to see a lot of athletes or anything like that, because there's so many different ones and you don't want to tape somebody wrong. All right, so our ACL. We're now getting into injuries and more specific treatments. So with the ACL, if there's a torn ACL, remember the ACL blocks the anterior glide or anterior translation of the tibia. So that typically occurs during extension or hyperextension. It also helps stabilize with knee valgus and varus forces and with rotational movement. So it helps to block the movement from going too far. Most of the time when someone tears their ACL, it's while their foot is planted and they're doing some type of a pivot movement on that planted foot. They typically hear a pop if it fully ruptures. It swells immediately within an hour of the injury. It's already swollen, and the knee will begin to give way. If it's a full rupture, they should notice some instability of the knee, that it's kind of buckling, giving way underneath them. Of course, ACL tears are more common in females. We know that's related to the increased Q angle, and one of the ways we fight against that is by strengthening gluteus medius and VMO. I lost my train of thought for so the pictures are the kind of special test of how we assess and determine if somebody has torn an ACL. Of course, an MRI will tell you, but as far as on the field, if we're determining can somebody go back into the ball game or not. So the Lockman test is this one below. So they're in about 30 degrees of flexion, and you stabilize the distal femur, and then you pull anteriorly on the proximal tibia. And if there is what blocks anterior translation of the tibia. So you're pulling the tibia forward to determine, is the ACL doing its job in blocking this movement? If there's significant amount of movement there, then we know there's probably a full tear of the ACL. Now, if there is, you don't feel like it's a lot of movement, but it's really painful for the patient, it may still be torn. It may be a partial tear. The other thing is the swelling itself acts as a chalk block, so it basically can block the movement and give you a false negative. So you may, if you do it immediately, like they're in the middle of a play and they fall down and you run out there and do it, then it won't be swollen enough to block that. You should get a true reading. But if you wait till the end of the game and then you're assessing on the sidelines, it may look like less of an injury than it actually is, because the swelling itself is blocking some of that movement. So just be aware of that. If they do have surgery to fix an ACL, then we avoid the short arc quads and the long arc quads typically for the first 6 weeks. Some of the open kinetic chain quad strengthening is contraindicated depending on the surgery and the surgeon, what exactly they did. So always familiarize yourself with the protocol, with what exactly the surgeon did and what they want you to do or not do, so that you don't jump in and think you're doing a favor and end up hurting the person. Whatever mentioned, the Lockman test is kind of the gold standard, but the anterior drawer test is basically the same thing. We just have the patient in more flexed position, and typically the assessor will either sit on or use one hand to block the movement of the foot to stabilize the foot, and then do the anterior translation of the tibia. So it is used also in assessing the anterior translation to determine if there is a tear in the ACL. So the Lockman as well as the anterior drawer. Okay. Now the PCL, again, its primary responsibility is to limit posterior glide or translation of the tibia. It's less common to tear it, but typically the way it's torn is a forced posterior translation with a bent knee. So maybe a hard fall on a bent knee, or sometimes with a motor vehicle accident, if the dashboard, if their leg is bent and it slams into the dashboard, that can sometimes also injure the PCL. If it is torn, they will often present with a posterior sag of the knee. So it should be going right there, should be going straight down but the PCL is not there to prevent the posterior translation, so it's sagging in that flex position. It's called a posterior sag sign, and you just put them in about 70 degrees of flexion. Oftentimes you'll put both legs up so you can compare one side to the other. Because although this picture is really obvious, it's not always that obvious in real life. And so bend both legs and then compare. And if the tibial plateau is more posterior than the femoral condyles, then that's a positive posterior sag sign. So most likely the PCL is torn. If the person has already had the surgery to fix a torn PCL, this one has a lot of restrictions. Typically, they're non-weight bearing for the first 6 weeks. They're put in some type of a immobilizing brace to keep them from doing many movements. So they're on crutches. So for the first few weeks, you could do crutch training. The surgeon may clear you to remove the brace for PT only, and maybe you could do some very gentle mobilizations or movements, just depending on what the protocol is. And then typically for the next 6 weeks, from week 6 to week 12 post-op, they're still only partial weight bearing, and they're in a brace that's still locked into extension. So that's a long time to be locked in one position. So once they are released from that, you'll have to really work on flexion range of motion. Luckily, the extension is maintained because they've been stuck in that position. And then you will do the same type of protocol once they're released from that, as far as strengthening and stretching the same areas as with an ACL injury, VMO, gluteus medius, stretching the IT band and the hamstrings, all that. All right, medial collateral ligament is the MCL, and typically, so it is responsible for limiting genu valgus, that medial force, and you test it by applying a valgus force, a medial glide, with the knee about 30 degrees of flexion. It's common for the MCL to be torn during an ACL injury. We'll learn in a minute about the unhappy triad, these injuries occurring together. And again, typically sports injuries or some type of, quick cutting movement, things like that. For the LCL, the lateral collateral ligament, it of course blocks genu varus, or that lateral force, and we can test it by applying a lateral force, a varus force, at the knee with the knee flex 30 degrees. Just like a quick side note, the ligament tears are the same grades that we learned when we were talking about the shoulder, for the shoulder. I just realized I made a mistake on the PowerPoint, but anyway, and so a grade 1 is a sprain where minimal fibers are torn. A grade 2, there is a moderate tear. There is some ligament laxity. Remember, this one is more painful afterwards, because there's enough of the fibers that are torn and enough that are remaining that there's a lot of tension with certain movements on the remaining fibers. And then the grade 3 is a severe or complete rupture. And although it's very painful at the time, afterwards you can move and pull and tug on the area, and there's nothing still connected to cause pain. It's very unstable, but it's not quite as painful to force those movements during the special test to determine what's going on. This is that unhappy triad that I talked about. So commonly and pay attention to this guy, in a injury of the ACL, the MCL and the medial meniscus are all torn at the same time. That is called the unhappy triad. And of course, they would be surgically fixed together. But that is a common injury coupling to see all those together. All right, meniscus tears. So typically they occur also during rotational or twisting type movements while the patient is weight bearing. Meniscus tears often can be kind of, although it would be an acute injury, there may be a chronic setup to that injury that they've been kind of tearing down and irritating the meniscus for a while, and then finally it tears. Typically, there is pain during time of injury, but the swelling is not noticed until the next morning. So it's not an immediate swelling. Immediately, they typically have pain, there's clicking, catching, and there's decreased proprioception, actually. Remember, a lot of your proprioception comes from the cartilage. So um, they may feel just like their knees unstable, even though if you test the ligaments, there may not be a lot of instability, true instability there. The medial portion, the medial 1/3 of the meniscus has very limited blood supply. And so if that's the only thing torn, they've not torn their MCL or ACL with it, then they may opt to not do surgery or to do a meniscotomy or meniscectomy. Either one. So you just cut into it, take that portion out rather than reattaching. So typically in an athlete, they want to reattach the meniscus so that they have as much cushion there as possible. But in just that average population, especially if it's an older person or something, they may just go in and scrape that part out because the surgery itself sets you up for a little bit of scar tissue, which sets you up for some arthritis. The injury also sets you up for arthritis. And then the main issue with removing the meniscus, or the portion that's torn, is that eventually it will create some arthritis. So that's one reason that it's often treated non-surgically, because the long-term effects after the surgery are not really that much better for a patient with the surgery versus without. If it's just the general population, nothing else is torn, and they're not going to constantly doing banging type activities on there. There are a few different types of tears. So on the side, we have different types of tears. And one thing that you'll notice with either a bucket handle tear or a flap tear is that there's periods of it being better and worse. Like the patient will say, like, okay, it's stuck, and then I move it a certain way, and it's like all of a sudden it frees up my movement. So it's like the bucket handle or the flap will kind of get out of place and block the movement, and they'll be moving, and they'll say it's really painful, and it's like catching and clicking, and it feels like it's getting stuck. And then when they move it a certain way, it kind of forces the flap or the bucket handle kind of fall back in place, and then they have good movement and the pain is gone. So if somebody is having signs, symptoms like that, then most likely they either have a bucket handle tear or maybe a piece of the meniscus that's flapping off and can get stuck and then go back. One of the ways we test for torn meniscus, so the special test is the McMurray test. So we flex and extend the patient's leg while we're internally and externally rotating. So typically we hold the foot and we turn it in and out as we're going through flexion and extension. So they're going more towards extension as we're rotating and more towards flexion. So you flex and extend very slowly and kind of do a, it doesn't have to be as slow of a movement, flexion and extension, using the foot to guide that. And then if they report that they have, you may even hear clicking or feel clicking and catching, and that they have more pain with that test, and most likely that would be a positive test. Most likely they've torn their meniscus. Again, a MRI would tell you the best. All right, overuse injuries. So we're about to go into the overuse injuries, but just kind of a general key about it. The patient will typically report gradual onset of pain and not necessarily a real known cause. I mean, they may say, I've been running a lot, or I've been, training for this or that, but they can't say on this exact day I did this movement and felt the injury. There's not a true pinpoint of the cause. It's just it started hurting and then it got worse. Some of the reasons that people commonly have overuse injuries are overtraining. So either they're increasing the word too fast. It's recommended that you don't increase the load more than 10% per week. So if it's somebody that suddenly decides they want to run a marathon and they haven't been running, and they're trying to run it 3 or 6 months from now, then they may be upping the load too fast. Another training error would be inadequate recovery time. So they're not taking days off, or they're running too many long runs, or in between their long runs, their short run is not quite short enough, or they don't have enough actual just true rest days, might not be stretching enough, or icing, or caring for that area enough. Another training error is excessive hill running. Going up and down the hills is a lot of strain on the knee itself and can cause an overuse injury. And then running in one direction constantly. If they're running the same path and it's slanted towards a certain direction, then that can cause an injury as well. So recommend switching the direction. That's one reason why a lot of at different tracks and stuff, a lot of times they'll have certain days that you go one direction and then the other days you go the opposite direction. But even if you're running from your house and you leave and you always turn to the right and do a big loop around and come back towards the left, well, next time if you can, turn to the left and do the opposite direction, to try and avoid that training error. And then faulty equipment, which typically has to do if it's a runner with their shoes. Of course, if it's a cyclist, it might be improper fit of the bike. I mean, depending on the sport or the activity, it could be many other things. But with a runner, it's typically faulty shoes. Either they have new shoes that they haven't broken in well enough, or more likely that they have worn out shoes that they need to replace. So a lot of shoe stores can make recommendations on how many miles they expect for you to be able to wear that pair of shoes before you need a new pair. In general, if you just have like a walking shoe or general wear and tear, then you could probably keep that same shoe for 3 or 6 months. But if you're training for a marathon and you're running a lot every week, then the recommendation, of course, is going to be a lot sooner than that, depending on the shoe itself and what activity you're doing on it. Okay, so some of the overuse syndromes. So IT band friction syndrome is one of the common ones. They typically have lateral knee pain. Again, no true MOI is mechanism of injury, so they can't point to this day I did this and that's what hurt it. Sometimes even with the IT band, they'll have some clicking and popping because it's so tight. As they do certain movement, it actually is kind of popping over the structures underneath. So they may feel some of that or even hear a little bit of that. This is the most common overuse injury in runners, the ITB friction syndrome. More common in patients with genu varus and overpronation. I bet that's supposed to say genu valgus and overpronation, because genu varus typically is with oversupination. Yes, it's supposed to say genu valgus, and I'm so sorry about that. Sorry about that. But I would certainly encourage the patient to switch up directions as they run, encourage them to cross train. That's kind of a big deal as well. Don't just run. See if you could do some swimming or some cycling, something that's less pounding on the joint that could still allow you to strengthen the muscles and get a good workout in. And then, of course, if they do have ITB friction syndrome, treatment would be a lot of manual therapy, myofascial release to the IT band and the TFL. Of course, you will also stretch those areas. Those are the tight areas. Strengthening of the gluteus medius and the quads, specifically the VMO, can help counteract that pressure on the lateral side of the knee. And then icing the area of pain, the area of inflammation. All right, patellofemoral pain syndrome. This is also known as chondromalacia. So there's a swelling and a deterioration behind the kneecap. Typically, the patient will complain of anterior medial knee pain, so front and middle of the knee is where they feel a lot of this pain. And it's often diagnosed in someone with a thing we call miserable malalignment. Miserable malalignment is where the femurs are internally rotated, causing the patella to be squinting. Basically, they're facing each other rather than facing forward. The tibia will then have to externally rotate slightly, and the feet will be flat. Now, in this situation, they've done glute med strengthening, BMO strengthening, and basically also changed the way she was standing. They externally rotated her feet to decrease the effects that her bone structure had on her standing posture, and that can take a lot of the pressure off of that area and decrease the wear and tear and the inflammation behind the kneecap. Um, so same commonly weak areas, same commonly tight areas as with others. One of the things that we may add to this treatment is patellar mobs. So again, if the patella are squinting in, or still, even if they start out in a squinted position, look at how they're moving, and if they have that J sign where they're moving lateral with quad contraction, and strength or mobilize in the direction that they're most limited. Doing some stretching and strengthening, and then proper footwear or orthotics. So orthotics are typically kind of custom built, and we can have a orthotist come in and measure the patient. Some PTs still do it. It's kind of a older trade. None of the new grads are really doing it, but some are grandfathered in that have been doing it for years. Otherwise, getting an orthotist to come in and make a custom-made orthotic can be helpful. Just be a little bit careful because, again, anytime we have extra bracing and whatever, we can get to a place where we're more dependent upon that. And so when it's removed, we tend to have less strength because we've been relying on that support. So just be careful depending fully on a brace. Okay, sorry, my allergies are messing with me today, so I have to keep pausing the video. Okay, plica syndrome. So plica syndrome, first I'm going to explain what the plica is. Plica are thin tissue folds that surround the knee joint. So there are 4 common plicas in the knee, and if they're chronically inflamed, then it can cause what is called synovial plica syndrome, which basically causes anteromedial knee pain. Again, the front and middle of the knee. There may be some clicking and popping, swelling. Joint effusion is just swelling inside the joint itself. The knee may feel like it's getting locked and hard to unlock, and then they have range of motion deficits and knee instability. So it's most common in teenagers and in adolescents, more common in women than men. There are some, so you can even be diagnosed with plica syndrome at a very young age, and so there are some little guys that already have some issue with the plica when they're small. So if it's not properly treated, then it can turn into that chondromalacia, the not miserable malalignment, patellofemoral pain syndrome that we just talked about. So you really want to treat it, loosen up the area, decrease the inflammation to the area, same type of treatments we've been going over in order to keep it from progressing and getting worse. And then it is something that can basically be, the symptoms can be fully eliminated with proper treatment. Sorry, I thought I was further. There we go. Okay. patellar tendonitis. So we've learned about tendonitis at the elbow and other areas. It's pretty much the same. Inflammation of the tendon. If it progresses, um, chronic inflammation, it can turn into tendinosis, which of course means that the tendon is starting to break down and more easily torn. So be very careful. It's one reason it's very important to treat it when it first starts rather than letting it go on. They typically have tenderness over the patellar tendon or the fat pad or inferior pole of the patella. It's more common in jumpers as they're pushing off, a lot of pressure with push off and with landing. Often their quads are tight. So this is kind of opposite, even though typically quads are weak and hamstrings are tight. In this situation, the quads are typically tight, and that pulls on the kneecap. So they'll have patella alta, where the kneecap is too high of a position. So stretching of the quads is really key here. Of course, you want them to rest from the activities that are causing the issues, and then stretch the quads. And it's key to use an offloading brace. With really any type of tendonitis, offloading braces are great to try and decrease the tension on that area. Modalities and ice to decrease inflammation, and then eventually you'll start generally gradually strengthening the area and returning more and more towards their functional activities. With a hamstring strain, those just torn muscle fibers in the hamstring. If one area completely tears, it will actually roll up and you'll see like a bulge in that area. If it's bad enough, it could be something that might be surgically fixed. I typically do not see that because there are those three muscles back there, biceps femoris, semitendinosus, semimembranosus, and even if one is torn, the other can help take over where that deficit is. So typically, I don't see it surgically repaired, but it is a possibility if it's torn bad enough. You can do massage techniques, especially if there is that bulge, kind of lengthening, pulling that area out toward more towards the normal fiber alignment, trying to get it to realign as it's healing. Ice and modalities to decrease pain and inflammation. Again, gentle stretching, gentle progression of strengthening as it's healing, because the more rigorous you're pushing on it, the more likely you are to kind of backtrack and not really help them heal, but help them maintain their injury. And then eventually, once they are healed well enough, then going back towards their functional activities, their sports drills. And throughout that, you'll still continue to stretch and ice and use your modalities to decrease the inflammation as you're kind of causing some flare-ups of inflammation with those activities. Arthritis, just like with any other joint, occurs with wear and tear. The osteoarthritis does. And with the knee specifically, often we'll hear grinding sound. So crepitus is kind of a sound or a feeling like you're stepping on glass or stepping on leaves. And a lot of patients will ask, why do I hear this grinding and feel this sensation? And that is called crepitus, and it is just a sign of arthritis. So we will treat it just like we would with arthritis and others, try and do some things that don't add a lot of pressure. So aquatic therapy would be good. And we want to get movement back in and help really get fluid joint perfusion, get fluid in and out of the joint rather than just settling in the joint, and maintaining the motion and the movement that they have. All right, patellar instability. So that is when the patella slips out of the trochlear groove that it should be remaining in. You can fully dislocate the patella. It's typically due to trauma. But with a full dislocation, they may actually have to go get it placed back in, like go to the ER and have it repositioned. Oftentimes what you'll see is a partial displacement. So it subluxes. So you'll see during the movement, it's moving out of alignment and then kind of pops back in. They're moving and it gets pulled out, and then they do the opposite movement and it goes right back. That's a subluxation. So they call them chronic patellar instability, that it just constantly with a certain movement, it goes out and back in. Symptoms include pain, stiffness, weakness, difficulty bearing weight, swelling, buckling, catching, and then locking of the knee. Initially, they'll typically require some type of brace and non-weight bearing, especially if they dislocated the knee, until it's healed and less likely to dislocate again. They'll typically be in a brace and not be able to put weight on it. And then once they're cleared for VMO strengthening, or for strengthening in general, we'll start with the VMO, stretching the IT band, performing patellar mobs, taping the patella into proper alignment, and all the other types of activities we've done for other new patients as well. All right, a Baker cyst is basically just a fluid-filled sac on the back of the knee. Baker cyst is on the back, the posterior portion of the knee. Causes pain and discomfort in that area. It can limit their knee flexion motion, but it's not something we really treat in physical therapy. It's going to be referred out and typically require surgery to actually get rid of. With Osgood-Schlatter, that is a condition that we see in children, especially children who are growing very quickly. So as their bones are growing, specifically the tibia, so increased growth of the tibia tubercle is what is caused by rapid growth spurts. So the ligament growth is not able to match the bone growth. So as they're growing, the ligaments are not able to, and the tendon as well, not able to grow fast enough in order to match the bone growth. And so typically the patellar tendon, where it attaches at the bottom at the tibial plateau, causes excess pressure with movements and things, as there's already tension on it with a person who is growing quickly. And then that pressure will stimulate the buildup of more bone in that area, because the bone is able to catch up, but the tendon and ligament aren't able to grow as quickly. And so then they'll have an excess of growth of bone in that area, so it'll look like a knot. And if somebody is referred to us with that, then we can help them by doing stretching and maybe some gentle strengthening. Typically it's more stretching modalities, decreasing the inflammation to that area. Ice, trying to get that area, an offloading brace could help get it less inflamed, and then that can actually decrease the amount of extra bone formation that occurs. Now, if you then down the road, once somebody stopped growing, have a patient that had it as a child, you're not going to change what bone growth they had. But if you're treating them while it's in active stages, then you may be able to have an effect on how much bone grows there. Blount's disease, this is a disease in children that basically causes the medial growth plate to stop growing. The lateral growth plate continues to grow, but the medial stops, which will cause bowing of the legs. It can be one leg or both. Obviously, in this picture, it was only on one side. And they can use, if it happens in while they're an infant, they can use bracing to help it grow more normally and not have such an impact. But if the condition is not corrected, with bracing and things by age 4, then the surgery would be the only option. So basically when a PT would see someone like this is possibly after a surgery to assist them with gait training, with strengthening again, with balance, stretching, and just, maintaining good alignment of that area. But otherwise, if we see a patient with this, I mean, we can still help make them more comfortable, but we wouldn't change without surgery. We wouldn't necessarily change the course of the event other than bracing, if it's somebody really young. Okay, so flexibility test. This is our last slide for the knee lecture, and then we will go into the ankle. Hamstring 90-90. You basically have the hip and knee flexed to 90 degrees, and then maintaining that hip flexion at the same level. You have the patient extend their lower leg, and you measure the mobility. So you could do it passively as well, but you take a goniometric measurement and measure how much movement they have to determine if the hamstrings are tight. The Eli's test is checking for tightness in the quads. So they lay in prone, and when you flex the foot up towards the butt, if the hip comes off the table, if it starts to kind of come up, that means the quads are tight. If it's able to stay down, then it's not. It's a negative test. Ober's test tests the IT band and the tensor fasciae lata. So you first abduct the leg to be kind of even with the hip level, and then extend slightly. So this is getting the IT band in a good position. And then you allow the leg to adduct. Now, if it adducts, the amount that it adducts determines if the test is tight or not. So if it's able to kind of fall in towards the middle without any real restrictions, that would be negative. But if it somewhat stays in that position, then that would be positive, that the IT band, the TFL are tight and holding that position. And then the Thomas test, they flex one knee, and then they let the other leg hang down. It should go straight down towards the table. It should not be flexed off the table. It should just lay flat. But if it is flexed, then that would be a positive test, meaning their hip flexors are tight. So we will do this case study in class together. I'm just putting it up in case somebody wants to pause it and read over it before class. And we're about to start the ankle lecture. All right. So with the anatomy, we'll just go over that in class together as far as the tarsals, the metatarsals, and the phalanges, and then some of the attachment points. The sesamoid bone is pretty easy to find under the first toe or the great toe. Plantar fascia is key. You will find that in each other as well, because a lot of patients do have plantar fasciitis. During observation, you want to compare the calf size on each side. You can even take a circumference measurement. You want to look for any deformities. So here are some of the most common deformities. Remember, there is a distal interphalangeal and a proximal interphalangeal joint in the toe, even though they're small. So mallet toe just affects the distal, hammer toe just affects the proximal, and claw toe affects both. So they look a little bit different depending on that. That's typically from a ruptured tendon, just like with the finger, like we learned about. Hallux valgus is another deformity, could be with arthritis. Bleeding, you look for bleeding, swelling, any calluses. Calluses form over pressures of increased shear force or increased weight bearing. And then shoe wear patterns. So most shoes should be worn the most over the lateral heel and then the first 3 toes. That's going medial out. When we're counting toes, we start with the big toe, so we go in to out. That's where the shoe should be worn down the most. But if it's in a different pattern, or it's all throughout the medial portion of the shoe, all throughout the lateral, tells you that you are probably overpronating or oversupinating. So overpronators, I'm so sorry. Overpronators typically wear out the medial portion of the heel and the remaining portions of the shoe, the medial portion of all of it. Oversupinators typically wear out the lateral portion of the entire shoe. And then you do have people, I like the bottom of these shoes, where the left foot looks like wear pattern's pretty normal. Looks like there's a little medial portion right there that's worn down. Then the right foot, there's this area here that they obviously put a lot of pressure on because it's just completely worn down compared to the rest of the shoe. So look for wear patterns, and that will tell you where they're putting the most pressure. You can also do a gait analysis, just looking at how they're standing, how they're walking, what areas seem to be affected the most. Palpation we will do in class. With the nerve patterns, when I'm assessing sensation, I assess the nerve roots themselves. So first I rub along the medial thigh, so that's L2, then the medial knee is L3, the great toe, especially the medial part of it, is L4, then the dorsum of the foot is L5. Now remember, the foot, it's like it was turned around because the top of the foot is called the dorsum, and the bottom is called the ventral surface. So it's as if when we were formed, it was turned around backwards and it was considered part of our back. But that's why dorsiflexion, you're actually coming up towards the front versus towards the back. But so the dorsum of the foot is L5, the pinky toe is S1, and then you can rub the lateral portion of the knee, and that would be S2. And that's just to determine if there's any compression of a nerve root, if they have decreased sensation in one of those areas. Then as far as the other nerve patterns, it's a lot of them. So I suggest kind of familiarizing yourself with those, and so that you can recognize symptoms in patients. General tips for foot and ankle patients. If a patient has bony tenderness to palpation and they cannot weight bear on a side after an injury, then they really should have an x-ray done just to make sure there's not a fracture there. So overpronation, okay. Typically, overpronation and oversupination actually begins at the calcaneus. So rear foot valgus, so going more towards the inside, the ankles kind of caving in, causes overpronation of the rear foot, and then the forefoot actually moves to the opposite direction to compensate. So if here's someone who's overpronating, and if they're not weight bearing, you'll see the entire foot is just kind of facing inward. But when they're weight bearing, so that the foot actually comes in contact with the ground, otherwise they'd just be walking on the inside part, the medial part of their foot. In order for the foot to contact the ground, the forefoot has to go towards the opposite direction. So if it's an oversupinator and they're walking on the lateral border, then the forefoot has to kind of curve in order to still contact the ground. That's compensated. So if the rear foot, if calcaneus valgus causes overpronation, the forefoot has to turn in the opposite direction into varus. With calcaneus varus, it causes oversupination, and the forefoot has to go into valgus to maintain contact with the floor. Our special test. So first we can test the gastrocs to determine if there's tightness in the gastrocs by doing passive range of motion dorsiflexion with the knee flexed and extended. If they have increased dorsiflexion range of motion when the knee is bent, then the gastroc was limiting their dorsiflexion with it straight. So it means the gastroc was tight. One way that we check how intact the Achilles tendon is the Thompson test. Don't confuse it with the Thomas test. This is the Thompson test, where you have them laying prone. You squeeze the calf muscle. If their foot plantar flexes, then you know the Achilles tendon is attached, because moving the gastroc is causing a movement of the foot. If it just remains in the same position when you squeeze the calf, then that tells you that the Achilles tendon is not attached. So that's a way of a positive would mean that there's probably a torn Achilles tendon. All right, plantar fasciitis. So that is inflammation of the plantar fascia. It can cause heel and foot pain. It's often worse in the mornings and after prolonged weight bearing. So at the end of the day, after they've been walking, it hurts. In the mornings when they first get out of bed, it hurts. Most people say the first step out of bed is just killer. It's also associated with heel spurs. So a lot of people will develop a heel spur right where the plantar fascia attaches, and that in itself is very painful. So treatment includes manual therapy, making sure they have proper footwear. Again, maybe orthotics, custom orthotics may be made. There's also now a lot of shelf orthotics, meaning you can go to like one of these specialty running stores. They can look at your foot and they can recommend a not custom-made orthotic, so one that's just on the shelf, but they have different ones based on what your foot does. So if you're an overpronator or an oversupinator or falling arch or whatever, they can kind of recommend which of those box orthotics you can buy and save a lot of money. So a lot of them are around $60 or so, whereas a custom orthotic might be like $300. And typically it's kind of rare for insurance to pay for a custom orthotic anymore. Some of them will, but so that might be an option for your patient if they really need an orthotic, but they can't dish out $300 right now. Then they can go and get like Happy Feet or Power Step. Those are some of the common names of a shelf orthotic that's already pre-made for specific people, and a lot of times it will help. It really will help the pain go away. Our focus will also be on anti-inflammatories. So one thing that we can do is freeze a water bottle and have them, I'm turning my alarm off. It's time for me to wake my kids up. So freeze a water bottle and have them roll it on the bottom of their foot back and forth, and it can kind of create that deep pressure like the manual therapy, but also with the ice for anti-inflammatory or for anti-inflammation. So typically we'll have the patient do that back and forth for like 5 minutes or until they're numb, and people get a lot of really good results for that. We also focus on stretching the calf and the plantar fascia, as well as strengthening the intrinsic muscles of the foot. So doing those towel scrunches. You could do object pickups with the toes, like your mama always told you to not do. Picking those objects up and moving them around, that helps strengthen the intrinsic, the small muscles of your feet that help support your arch and posture. So with plantar fasciitis, the main thing is getting the inflammation and the tightness out. So gastroc soleus stretching, really doing deep tissue work on the bottom of the foot, the plantar fascia, and on the calf. Sometimes ultrasound as well. Modality I typically will use is a pulsed ultrasound to decrease inflammation and to promote healing. All right. So, ankle sprain. The ankle sprain, remember we've talked about before, is actually a torn ligament in the ankle, not just like a, most people, or at least I thought before I went to school, that an ankle sprain was just kind of like a bruise or a, pull of a muscle, but it's actually a torn ligament. The most commonly torn ligament is the ATFL right here in the front, and the second most common is the calcaneofibular ligament right behind it. And a lot of times people will hear a pop. Typically for those two ligaments especially, it occurs by them rolling their ankle outwards. So basically a severe oversupination, typically during weight bearing, maybe stepping off a curb wrong or playing a sport or something, kind of tripping up over your feet. But if the ligament fully ruptures, often people will hear pop. It will swell up and bruise pretty quickly as well. You have pain in that region. It's typically the distal lateral malleolus. It could be the medial malleolus if you sprain the medial ligaments, and that would be a severe overpronation, but that's not as common. The pain is worse with weight bearing and with movements of the ankle. And the biggest thing as far as physical therapy that we need to pay attention to is that an ankle sprain greatly impacts your proprioception and increases the likelihood of another ankle sprain in the future or falls or things like that. So after an ankle sprain, it's key for someone to do balance training, proprioception training, gait training, all of those things. So bracing and taping are good, especially initially. Even after, if it's a chronic ankle sprainer, then they may need to wear some type of brace or something every time they play their sport or do any type of, running, lateral movements, jumping, working out, things like that. Again, with a brace like that, the more you wear the brace, the more you become dependent upon the brace. You can turn it off, baby. And then, so you have to start out wearing the brace and then wean yourself off of it. So don't just go from full brace to no brace. You kind of have to wean yourself off of it, because as you wear the brace, the area gets weaker, and then you need to strengthen it up without the brace. But again, in a high contact sport, or maybe it's soccer or something where you're running, cutting back and forth, they still probably need to wear the brace even after strengthening. Modalities, manual therapy to decrease inflammation. Also working on the plantar fascia, because oftentimes that will get some adhesions, especially if they're stuck in a boot for a while. If they have any type of injury where they have to wear a boot, keeping them in that fully guarded position for so long can actually stir up some plantar fasciitis. So I would work on that area, on the gastroc, the soleus, those areas. Start stretching and then begin gradually strengthening, and eventually doing more and more functional training. Single leg stance, BAPS board, Bozu ball, standing on the trampoline. Different surfaces are key in building that proprioception, especially single leg activities. Achilles tendonitis, just like any other tendonitis, inflammation in the tendon. If it begins to break down, of course, it's tendinosis, which makes it more likely to tear. The pain is worse with dorsiflexion, especially while they're standing in a weight-bearing position. But the plantar flexors are weak. Remember, the plantar flexors are what connect to the bone through the Achilles tendon, your gastroc and soleus. So they are going to be weak, because when you do a strong contraction, it puts a lot of pressure or tension on the tendon and causes it to be more painful. Treatment, of course, just like with other tendonitis modalities, anti-inflammatories, if they need bracing or taping, friction massage to decrease the adhesions. That's one area I find a lot of adhesions when somebody has Achilles tendonitis, is in the Achilles itself becoming very firm. It'll kind of thicken. Stretching and then gradually strengthening, of course, gait, balance, and proprioception training as well as you're returning to function. I would certainly have them rest from the activity for a while, even though a lot of people that come in with Achilles tendonitis are very active and don't want to slow down. That's been my experience anyway. All right, with fractures, there is such a thing as a bimalleolar fracture, where both the medial and lateral malleoli are fractured during dorsiflexion and eversion injury. So if you kind of jump down on it wrong or land wrong, it could also be in conjunction with an ankle sprain, all of it together. But there's such a thing as a trimalleolar fracture, which there's not 3 malleoli, but it also involves the tibia. the posterior tibia. The end of that breaks off. So up here it's labeled as posterior, but that would be if all three of these areas are fractured with one injury. That would be a trimalleolar fracture, something you don't want. Most likely they will have weight-bearing guidelines. Most likely they'll have a non-weight-bearing status for a while, and then the orthopedist will have to clear them for when they can begin partial weight-bearing or however much percent they feel is accurate. So crutch training, teaching them proper use of assistive devices at first, and then once the immobilizer is removed, which recently they've kind of switched over from cast to more, you've seen the boot or some type of removable immobilizer. For kids, they will still do a cast, but for adults, most of the time they will do just some type of a removable immobilizer so that they can not get quite as many of the effects of immobilization. And they'll tell them either keep it on only all waking hours or only remove it for showers, or they'll tell them specific guidelines on when they're able to remove that. But once the immobilizer is off, you can begin gait training, balance training, proprioceptive training, of course, within their weight-bearing guidelines. Manual therapy, again, if they've been in an immobilizer, work on the plantar fascia, work on the Achilles tendon. If everything's just been sitting still for several weeks, you're going to have to really push passive range of motion and start stretching and working through that area. And then eventually stretching and strengthening. Of course, you can continue taping the area or bracing the area depending on how much support they need, and eventually get to functional training as well before they return to whatever their normal activities are. Arthritis. Often arthritis will sit up in the first MCP joint, so MTP, metatarsal phalangeal joint. And as we saw earlier, that can create that deformity on that first slide, the hallux valgus. That's typically from severe arthritis in that joint. So you can see how it kind of forces that sideways and pushes the toes more, or at least the great toe, more laterally. Proper footwear is definitely needed. So, good tennis shoes would be good, but a custom-made orthotic might be beneficial depending, or it may be beneficial also to wear some type of a little pad over the outside so it doesn't get rubbed and create more of a bunion or a callus over that area. And then general stretching modalities, manual therapy to decrease the pain and increase the movement. Remember, with arthritis, movement is key, and so just getting everything moving well and maintaining what they do have is the goal. All right, with Charcot foot, we've talked about this before. It's seen in patients with diabetes. So it can also be with anybody who has poor circulation, and that poor circulation then decreases their ability to heal, and the bones in the foot begin to deteriorate. Okay, remember, our feet are hanging down in a dependent position, so if there is blood pooling somewhere or gathering somewhere, oftentimes it will be whatever's the lowest, which would be our feet. And as we've talked about, you all know I have an affinity for diabetes, that as blood stays in the area, so with diabetes, the glucose is a big particle. It's going through the blood vessel and it's rupturing the capillaries because it's too big. The glucose is the largest particle in your bloodstream. As it ruptures those capillaries, then there is less blood getting to the area because the capillary is missing. But there's also less blood being removed from the area. The capillary system is responsible for that. So then there's swelling in the area, but the toxic products are staying in the area and new nutrients are not being delivered to the area. And so it becomes just this pool of useless old blood where all the good particles have already been removed and the bad particles are just building up, that over time then deteriorates the tissues in the area. And so it's very obvious when the bones in that area become soft, and then they start to fracture really easily, and it will lead to a severe foot deformity. And I have seen offloading braces, or not just braces, shoes, but they can get fit for that, where they can walk with this special shoe that has this big buildup underneath, where they're actually weight bearing through like the calf and the upper part of the leg, and not putting actually any weight on the bottom of their foot, which can help, because walking on very brittle bones causes more fractures. So I have seen people with shoes, specially made shoes, that can help the injury. We typically don't necessarily get people referred to us just for Charcot foot. Like, they may be referred for something else and they happen to have it. But most of the time this is treated medically. So I would say for us, just keep it in mind if we happen to have a patient who had a stroke or something and they also have this going on, that it is painful to walk on, and that they typically don't have a lot of sensation, but then the sensation they do have is pain. So they don't have a lot of awareness of where their feet are. So gait training and balance training becomes really difficult with someone with this diagnosis. Weight bearing tips, just some general tips. So we always correct poor habits that lead to pain, inflammation, weakness. So like the overtraining, like we talked about with the knee. If they are walking with severe overpronation or severe oversupination, we might try and recommend an orthotic insert, and if they, or a special shoe that's kind of built up more in that area. If they are leaning too far forward, we may try and loosen up the psoas and get them standing up straight. So correcting those poor habits, educating about training errors like the proper footwear and the need to get new shoes every so often, the need to change up the direction when you're running. All those things are key. Then assist in normalized gait pattern to decrease fall risk and risk of re-injury. Strengthen the muscles that seem to be weak, stretch what's tight, and then work on gait training specifically with whatever they're lacking, taking larger steps, picking their leg up higher, trying to work on normalizing that gait so they're not at risk of re-injuring. And then with stair training, you all know this, but just a reminder, we always stand below the patient as we're guarding, and typically when we're doing gait training, then we're behind the patient. You guys know that. All right, with manual therapy, you can do your soft tissue, deep tissue, myofascial release to the plantar fascia. That's one of the common areas that gets tight, to the gastroc. Sometimes even a little higher past the knee, but typically we stop at about the knee for most of our ankle and foot patients. And then passive stretching, especially in dorsiflexion. Typically dorsiflexion is limited, and plantar flexion maybe even in excess depending on the patient. For our joint mobilizations, we can do a distraction of the talocrural joint. So this hand is just stabilizing. You kind of cup around the talus with your other hand and do a distraction force inferiorly. And it opens up the joint space, just kind of allows more movement there. So that's kind of one of our starting point joint mobilizations, getting the joint space nice and open. And then with a posterior glide of the talus, this arm is stabilizing behind the distal tibia. Then this hand is really closer to the joint, just slightly, and adding a posterior glide of the talus, and that can help you with dorsiflexion range of motion, and we'll work on that in lab together. How I like to hold the foot is I like to actually hold, if this was the foot, hold the foot in my hand like that, and then the other arm pointing down so that I can dorsiflex. I have to be in a different position so I can dorsiflex as I'm doing the mobilization. It's hard to tell with this, right? But I will do the talus glide with some dorsiflexion, because if the talus is too far anterior, it blocks dorsiflexion. That's why we want to do a posterior mobilization to get it out of the way and get as much dorsiflexion range of motion as possible. So we'll work on those together in lab. Posterior glide of the distal tibia can increase plantar flexion. The tibia ends up being concave on top of a convex talus. So with the tibia and the fibula together, the way they're shaped, it's a concave moving on a convex. So remember, with a concave, as the swing of the bone, so we'll say it's going anterior, the glide and the roll all go in the same direction, anterior. And so if you're trying to do plantar flexion, this is the foot, then as the foot goes down, then so everything's going posterior. Everything, if you're just moving the tibia on top of the foot, it would need to move in a posterior direction to allow the foot to plantar flex a little bit. I'll show you on the skeleton in class. I rarely run into anybody who needs more plantar flexion, so I haven't actually had to use this one, but that way you know, when you can see, I switched so you could see better this picture, and I just realized it's super zoomed in, and now you still can't see what he's doing. So with first MTP distraction, so you're stabilizing the tarsal, then you are mobilizing the phalange, or you're stabilizing the metatarsal, mobilizing the phalange by pulling into kind of a distraction force. So you're kind of pulling away from the foot, and then you can do dorsal and plantar glides. So remember, the dorsum of the foot is actually the top of the foot. So a dorsal glide would be towards the top. A plantar glide would be towards the bottom, to the plantar surface of the foot. And then you can also do calcaneal inversion and eversion to increase inversion and eversion. So grabbing the bottom of the calcaneus and turning it in and out, kind of a rocking motion back and forth, and you'll stabilize the tibia. We'll practice that as well. All right, some of the modalities we typically use on foot and ankle patients: ultrasound. The more I talk about ultrasound, the more I'm like, I must really like ultrasound. I didn't even realize. Fluidotherapy, of course, we've talked about. You can do it with feet. I don't see it in clinic a lot, and it's really hard to get somebody in the right position to put their foot in. So it's not as realistic, but it's certainly possible. Laser therapy, you may be able to do in certain cases. I don't see it a lot in the clinic either. E-stim, just for pain gating. Ice or heat, just depending on which one they want. Of course, I go towards ice. Most of these are inflammatory conditions, so we want to decrease inflammation. And then with your iontophoresis, which is what he's putting on it down here, less common these days in clinic, but it's a great modality when available to decrease inflammation. Stretches, so typically we want to stretch the gastroc and soleus as well as the plantar fascia. Remember, the gastroc, your knee is straight. The soleus, the knee is bent. So both of these would be stretching the gastroc, but you could do both of the same stretches to stretch the soleus, just bend the knee. With your plantar fascia stretch, typically we'll start out with them just grabbing their toes and pulling them superiorly, and that will stretch that. But you can also do it up against the wall or do more of a kneeling pose to stretch that. With the stretches, the non-weight bearing is less pressure on the area, and you can progress towards a weight bearing position, especially with like maybe Achilles tendonitis or something where you don't want to overexert and put more tension on the tendon itself. All right, passive range of motion in general. So we have some normative values I do want you to look at and pay attention to with our ankle movement. So with dorsiflexion, 0 to 20 degrees is normal. I find most people are more towards the 0 degrees, 5 at the most. I've come across some people with 10, but not more than 15. That's a lie. One person, but she had club feet, so her foot was straight up. Plantar flexion, normal is up to 50 degrees of plantar flexion. Inversion, normal value is 30 degrees, and eversion 20 degrees. With our range of motion, we can do mobilization with movement like we talked about for the hip. This one would be doing a posterior glide of the tibia while they're doing either step forward or lunges or squats. So while they're doing a motion to try and assist with the movement. The problem is, remember earlier when we were doing joint mobs, a posterior glide of the talus can help with dorsiflexion. A posterior glide of the tibia actually helps with plantar flexion, and typically dorsiflexion is what we're looking for. So you have to be really specific and really careful with this mobilization with movement that you're not accidentally targeting the wrong area. So just depending on what the patient needs, pay close attention to that. And then the ABCs, that's one of the great range of motion exercises we like to give patients. They could do it with a wrist patient or an ankle patient, writing the whole alphabet with their foot. I mean, not on paper, just in the air, to get full range of motion, or to really work their foot through their full range. All right, so with strengthening, we of course start with isometrics, just tightening up the muscles in one position. You can do TheraBand ankle weights. This is a nice, interesting way to add weight during a calf raise. Tau scrunches are great because they strengthen the intrinsic muscles of the feet, so and help supporting your arch. And then object grabbing does the same thing, so picking up objects with your feet and putting them in a basket or moving them around from one side to another. And then standing hip four-way is a good ankle strengthening because the ankle you're standing on has to do a lot of isometric contractions as you're moving the other leg throughout different directions. So any single leg stance activity on the involved leg, but especially if you're doing maybe ankle or hip four-way because you have a TheraBand on the other leg and you're going against resistance, so you're having to work even harder to stabilize. That's a great exercise. Here they're just showing you how to help focus on inversion, eversion up here, and inversion down here if that's one of the things that you're wanting to strengthen, kind of like an isometric pushing into the doorway. Balance and proprioception training. So again, you can start out bilateral, and then a progression of that would be going to single leg stance. You can do eyes open or eyes closed. Eyes closed is the harder. You can start out still and then add some movement. You can go from a level surface to uneven, from closed environment to an open environment, which mean instead of a private treatment room, now you're surrounded by other people or moving cars or TV that's on, something that's distracting. All of those can help progress your balance exercises. Some specific exercises you can do standing on either a BAPS board or a rocker board. You can stand on the trampoline, a mini trampoline, or a Bosu ball. All of those things are great surfaces to start balancing on, and while you're standing on there, you can pass a ball back and forth. You can hit a balloon. You can try and juggle or grab clothespins out of somebody's hand and put them on a line or on a piece of paper or in a bucket or something. The options are endless. With gait training, you want to focus on whatever's lacking. If they are lacking dorsiflexion, try and get as much motion as possible, and then cue them throughout the gait to pull their toes up and whatever they need cueing on. Trampoline balance, we just talked about. Sports drills, just like the ladder drills we talked about before. You can go in and out, forward, backward, sideways. You can get creative there, and that's great. Cutting movements are key in the return to function stage. Proper footwear. So just in general, proper footwear. There are various types of orthotics. We talked about the orthotics. Again, some of the PTs used to make them. I find very few that do now. So most of the time we call in an orthotist. A lot of them will even come to the house or the clinic and make it for the patient. But that can be expensive, and insurance may or may not pay. Could get into a shelf orthotic, but whether it's a custom made or a shelf orthotic, and whether or even a new pair of shoes, you need to make sure you break into them. So if they got a new orthotic and they went to work and stood for an 8-hour day in a brand new orthotic, they're going to be super sore. So we recommend doing 1 to 2 hours the first few days. After about 3 days, they can increase it to 3 or 4 hours, and then they need to be in it, frequently for a week or more before they try a full 8-hour day. So sometimes they may need to start by using it at home, where they're more up and down, and then they may eventually build up to take in an extra pair of shoes, and they wear the new pair of shoes with the orthotic in them until lunch, and then they change their shoe at their lunch break so that they don't really make themselves sore. I think I've told you all this before, but I decided while I was in PT school that I was going to get a special shoe to help with my overpronation. I had been training for a half marathon, and I knew I overpronated and my medial knee hurt and all this. So I got on and went and ran like 13 miles, and I didn't run the race, but it was like we were supposed to run 11 and we got lost. So we ran for 13 something miles, and I tore my medial meniscus because it was extra buildup on the medial part of my foot and in an area I wasn't used to, and a brand new pair of shoes, and I just was like, this is going to be great for me. And it wasn't so great. So especially with running or activities, break the shoe in before you go straight to it. With the braces, these are still orthotic type of braces. This is an AFO, ankle foot orthosis. They're named based on the most superior joint they pass. So if it's the ankle, then it would be a AFO, ankle foot orthosis. For the knee, it's KAFO, knee ankle foot orthosis, and then hip knee ankle foot orthosis if it passes the hip. We'll have a full lecture on that in the future. So that just a basic understanding is good now. Importance of shoes and good house shoes. Okay, so here's the thing about shoes. Shoes are great. They add support. They can really help foot pain. But if you become too dependent, I mean, it's still good to sometimes kind of challenge your feet a little bit, again, just gradually at a time. But you can become dependent upon that support to where now when even walking around the house, you need a good supportive pair of house shoes. You need, you can't just go to the beach and all of a sudden walk around barefoot for hours and not be sore because you've not went barefoot for a while. So I would recommend, especially with your children, like as they're learning to walk and as they are running around playing, to encourage going barefoot. I think it really helps build the muscles of the foot up. And I think one of the reasons why so many people, especially like my parents' generation, those that are kind of in retirement age now, have so many foot problems, and this is just my opinion, is because when they were kids, there was this shoe that was really popular, and it was like a hard bottom. It was like a stiff bottom leather shoe. So it was just completely rigid at the bottom, and then the top was leather, a real cute little shoe. And they would put their babies in it when they were learning to walk because the stiffness of the shoe helped kind of stabilize them a little bit. The problem is if you're learning to walk in such a stiff shoe, you're not building any of the muscles up in your feet. And if you just go from baby on always in shoes, that's not ideal. Your feet are going to get weaker and weaker. Well, then eventually that weakness can, wear down on the foot. So I do think you're setting yourself up for foot problems if, especially from a childhood on. It's different when you're grown, but that you always wear shoes all the time. So I recommend playing around barefoot. Okay, so the other thing about shoes is you do want the toe box to have enough space that there's about a half inch surrounding the longest toe, a half inch past the longest toe, and that there's a little space surrounding all the toes. So I know the pointy toe shoes were real popular when I was in college, but if they are so narrow that they are pushing in on any of your toes, then that's not a good idea either. One way that we can know if a shoe is knockoff or not. So I do recommend people wearing brand name shoes. Now I don't have a specific brand I am out there endorsing or anything, but if you go, you buy a new pair of shoes and the orthotic insert, well, it's not an orthotic, it's just an insert, can be removed easily, then that's considered a brand shoe. The knockoff shoes are the ones where it's glued down. So sometimes even you'll get what's considered a name brand. Maybe you got it at, a consignment store or a wherever type of store, and you'll get it home and you'll realize it's glued down. So that just tells you that it's kind of poorly manufactured, and they're gluing it down to hide the evidence underneath. And so I always, when I'm searching for new shoes, I pull out the insert and make sure it comes out before I buy them. And that's a good way to know if it's a good shoe or not. And then taping, we're going to go over taping later on in lab, and these are just some basic techniques. I do highly recommend you getting trained in taping, doing some CEUs if you plan to do it very often. This is a heel lock where you're wrapping around and locking the hip into place, heel, trying to guard it from over supinating and causing an ankle sprain. So trying to guard that. Here, the top piece of tape is just a anchor, and then you have a piece of tape on the medial side that you're bringing down and around, and the force is pulling up. It's trying to support the arch. That's the low die maneuver. You can use some of these durable, the white athletic tapes, and you can help support the arch, or you can help block certain movements. For an ankle sprain here, this one's for ankle sprain, sorry. Then you start out, if you're using that stiff tape, you typically start out with a pre-wrap so that you're not breaking down their skin, taping them over and over. And then you anchor above and you wrap around until you are able to anchor below as well. One of the things I would, so they're anchoring above and below, and then they are applying strips of tape in a pattern to support the area. What was I going to recommend? I just had a recommendation on the tip of my tongue for you. You do want to, if you're doing that type of tape, of course, you want to have them in a dorsiflexed position. I'm sorry, I don't remember what I was going to say, but I'll probably remember it for lab for you all. All right, return to function stage. Again, sports drills and functional training are key. We do want to still use tape and braces whenever necessary. Make sure we continue using the ice so we decrease any flare-ups that are coming about. And then we want to gradually progress strengthening, gait training, balance, proprioception, all the things we've been talking about. We will do this case scenario in class, so if you want to pause it and read over it, you're welcome to. Otherwise, I will see you guys in class.